Next up, I'll invite Alicia-Marie Conway to the stage. She's going to talk to us about cell-free DNA and biomarker discovery. So thank you.
Good morning, and thank you very much for taking the time to listen about my update on blood-based biomarker discovery in cholangio. A bit like Jen, I have a disclaimer. My work started in cancers of unknown primary, and that's where the roots of all the cholangiocarcinoma research has come from. So I work at the Christie Hospital in Manchester and also at Cancer Research UK National Biomarker Centre, and I'm 50% clinical and research. So I probably don't need to summarise cholangiocarcinoma and the difficulties we have as a diagnostic challenge. We've heard a lot about that today, over the last 3 days. Unfortunately, we pick it up late, and it relies on a really invasive biopsy that often fails in a quarter of patients. So the parallels with cancer of unknown primary is that is the epitome of a diagnostic challenge. So patients are diagnosed with metastatic cancer, but all of the tests, including the biopsy, fail to identify where the cancer started. So my research and my PhD actually was trying to look at better ways to diagnose cancer of unknown primary. But as part of that, we sort of did a local review of all of our patients that were referred with provisional cancer of unknown primary to the Christie Hospital. So over a 3-year period, we identified 228 patients, and we decided to review their radiology to look at whether we were misclassifying some of these patients as cancer of unknown primary, the hypothesis being that some of these patients may well be cholangiocarcinoma. So we narrowed it down to just those patients with liver involvement, which was 71 patients. And we performed, as a HPB oncologist, I'm in the room, and a radiologist reviewed these radiological images independently. And they were looking for the typical radiological appearances of intrahepatic cholangiocarcinoma. So there you can get capsular retraction. If there's a dominant liver lesion, if there's peritumor enhancement, then you really can diagnose intrahepatic cholangiocarcinoma radiologically, but you do need to be an expert in the field. These are rare cancers, so they can get missed. And we know pathologically there's not very many markers that tell us that it's intrahepatic cholangiocarcinoma. So of this whole cohort of 228 patients, we found that when you're referred with a diagnosis of cancer of unknown primary, in around 20% of cases, we can make the diagnosis. So that's similar to international cohorts. You'll see there's a wealth of different tumour types, but lung and breast are the most common. But when we've retrospectively looked at this cohort, 10%, so 1 in 10 patients actually probably had an intrahepatic cholangiocarcinoma, and that's actually a third of patients with liver involvement. So we really are missing these patients. Since we published this work, there's a big CUP trial that has reported. They've done several publications. So it's the largest international CUP trial to ever have been undertaken. It was performed by Roche, and the aim of the study was to do tumor-agnostic, molecularly guided therapy. So all patients had mutational profiling, and then were hopefully enrolled onto a targeted therapy or immunotherapy. One of the first publications to come out was about the screening process and actually how difficult it is to actually identify patients with CUP correctly. So of 1,500 patients screened, only 52% were enrolled, and 20% of those patients had a primary tumour diagnosis made on central pathology. And you'll see for a rare cancer type, intrahepatic cholangiocarcinoma was the 5th most common tumour, along with the ones you'd expect, lung, breast, pancreas, the more common cancers. So even when you have central pathology review, even when you're enrolling into a trial, central pathology review can pick up these patients. One caveat is they didn't look at radiology in this study. So it's led to a change in the ESMO CUP guidelines and specific algorithms to help people identify the difference between cancers of unknown primary and cholangiocarcinoma. And this is really where expert MDTs come into play. But what I think is more interesting is that of those patients that were enrolled on study, they actually looked at the mutation profile of these patients, and this study clustered patients by their mutational profiling. So this is Foundation Medicine panel. And they found 10 different clusters, and some of them aligned to the molecular profiles of known tumours. So in there's a cluster that looks a bit like renal cell carcinoma, another cluster that looks like lung cancer, and 2 and 6 look a lot like cholangiocarcinoma. And that's 120 patients out of the 450 that they've looked at here. That's 25% of this cohort. I'm not saying they're all cholangiocarcinoma, but there's lots of FGFR2 fusions, there's lots of IDH1 mutations, as particularly R132C. So even within a really well-run, robust trial, could there still be patients with cholangiocarcinoma hidden amongst these patients with CUP? And of note, patients with FGFR2 fusions did a lot better on the trial if they got enrolled onto a targeted therapy, as you would probably expect. So we've talked in the conference a lot about when we should be doing molecular profiling. Should we be doing it earlier, because it can help the diagnosis, especially if we're carrying these sort of pathognomonic mutations, and we know we've got liver disease, does it point to cholangio? And definitely in CUP, we're moving to try and get molecular profiling up front because we think it will help the diagnosis. But the huge challenge is the lack of tissue. So we know in CUP datasets and in cholangio datasets, sometimes you're getting up to 40% failure rate because you haven't got enough tissue to do the mutation profiling. So my PhD was looking at ways to overcome the lack of tissue to make a diagnosis, and focused on cfDNA. So just to sort of go back to basics, everybody has CF cell-free DNA in their plasma, and you can extract it. It's very small amounts, and we can sequence it. In cancer patients, a small proportion of this arises from the tumor. So when we're saying we're looking at ctDNA, that's a tiny fraction of the normal component of your cfDNA. The way we identify ctDNA is looking for the molecular changes that we know about in the tumor. So we've heard a lot about mutation profiling. So mutations are the most common way to identify ctDNA, but there are more and more molecular techniques. And my PhD focused on copy number analysis. So that's where you get gains and losses of whole parts of your chromosomes, and that's part of the carcinogenic process. And also epigenetic changes. So I looked at an epigenetic change called DNA methylation. So this isn't a change to the structure of the DNA, it's a mark on the DNA. And the patterns of these marks are a fingerprint to your cell of origin. So each cell has a different fingerprint. It's tissue specific, but it's also tumor specific because you get widespread DNA methylation changes in tumors. We know that from the Cancer Genome Atlas data. So if you look at the DNA methylation changes from tissue of all the different cancers we have in the Cancer Genome Atlas, you'll see they cluster really nicely by tumor type. So we wanted to harness this data and try and design a cfDNA methylation tissue of origin classifier. To use this data, which is in tissue, we had to build a machine learning classifier that could find the diluted tumor signal. So as I said, the tumor signal's really tiny. If you trained a classifier just on tumor tissue, it wouldn't pick up that really subtle signal. So in silico, we diluted the tumor signal in what we would call the normal cfDNA. I've reduced down a lot of bioinformatics work to just a computer there. It took a lot more work. So we called this classifier Cupid, and then we've tested it in 142 patients where we knew the cancer diagnosis. So we found that we had 87% sensitivity. So there is a sensitivity loss when you get very, very low fractions of ctDNA. But we found when we did make a tumor diagnosis, we were correct 96% of the time. So the algorithm was very good at separating out these tumors. But you'll see that we only had 9 cholangiocarcinoma patients to test it on. And given how important it is in the diagnosis of CUP, actually we wanted to see how well it performed in a larger cohort of cholangiocarcinoma patients. So that's where the AMMF have funded the work to expand this, testing Cupid in cholangiocarcinoma patients. So we have a great biobank in Manchester that has stored plasma for many, many years. So I was able to access 75 patients' plasma samples, extract the cfDNA, and perform our in-house DNA methylation assay. This assay gives us two readouts. It gives us copy number analysis and the enriched DNA methylation signal. So can we detect ctDNA in cholangiocarcinoma using this technique? The first thing to note is the cfDNA yield, so that's all of the cfDNA that we extracted per mil of plasma, was significantly higher in intrahepatic cholangiocarcinoma samples compared to extrahepatic. When we use copy number analysis to detect tumor fraction, we could detect ctDNA in 21% of samples. That technique is only, the lower limit of detection is only 3%, so anything below that, we don't call it ctDNA positive. And again, intrahepatic have much higher tumor fraction. So how did Cupid perform? So Cupid has two outputs. One is a broad cancer prediction, so that's lung, breast, gynecological, or upper abdominal. And when we just use upper abdominal prediction as a detection of ctDNA, we can detect cancer in 47% of cases. Only 22% of those did we actually get the correct cholangiocarcinoma diagnosis. So the Cupid algorithm might predict pancreas, upper GI, or liver cancer. And that's because the algorithm's been trained on 29 tumor types, but also we know that these cancer types are molecularly similar, so the classifier finds it difficult to separate them out. And again, most of the correct diagnosis were in intrahepatic cholangiocarcinoma because they have this higher tumor fraction. So there's lots of work that we're doing ongoing to try and improve Cupid, and one of those is to improve its diagnosis for cholangiocarcinoma specifically because we know it's so important for patients with CUP. The algorithm is only as good as the training data, and we were just limited to only what was in the TCGA, but we're actually starting to build our own DNA methylation atlas for some of these rarer cancer types that aren't well represented in the publicly available data, and also expanding it to other biliary tract cancers like gallbladder and ampullary. And not only sort of using the same model and approach as Cupid, we're actually trying to develop a biliary tract specific classifier. So actually, if we take only the biliary tract cancers and look at the differences between them, we can choose the right genomic regions that are actually more specific for subtyping. And that work is actually really promising, that we can actually improve the sensitivity and the accuracy in cholangiocarcinoma. We've got access to more cholangiocarcinoma plasma samples, so from a Dutch biobank, and once we have a good test, what's good enough will be the question. I want to test larger cohorts of patients with CUP because I suspect we're still missing patients with cholangiocarcinoma, and the true prevalence is probably higher than we think. And we're really lucky that we've got access to blood samples from the Capisco trial, so that's nearly 500 serum samples, as well as some in-house trials that we've run as well. So this was definitely a team effort. So everyone at the CRUK National Biomarker Centre that supported me, especially all the bioinformatics work that's gone on in the background. I'm supported by those at the Christie, especially Mairead and Natalie. And the MCRC Biobank has been crucial to help us with the samples. It's thanks to the patients that have donated these blood samples for free that I'm able to do this work. But also it's been funded by AMMF and the Cholangiocarcinoma Foundation, and they've really spearheaded my research into cholangiocarcinoma. So thank you very much.